We are here to talk about triangles. And as we talk about triangles, it's three of us. And what's about the triangle we will show in a few minutes. But first we want to go back in history because we want to tell the story about Gematik and why we're here. So around 1999, the year 2000, there was a tragic incident with a serious drug interaction that caused more than 100 deaths. And for that reason, to overcome these problems with drug interactions, the Gematik was founded. And over the years, we spent many time on several projects in digitization in Germany. But only since the COVID pandemic and the upcoming FHIR expertise, we built some very good digital applications. One is the e-prescription that is now in production in Germany for in wide use for only several months. We have an email system and the electronic sick note that is sent from the doctors to the insurance companies is the major use case we use at the moment. And we also started with the electronic health record in 2019. And now we do a major rework on the electronic health record. And this, for the moment, makes 3 silos. And we want to connect the techniques in the modules we use. And this makes up a triangle here. So we have the healthcare service, which makes like a digital twin of all the data about a patient. We have the workflow engine starting with the e-prescription, and we have a communication service. We started with email. We also have a messenger working with the matrix protocol. And the triangle is made up of the connection between these 3 paradigms. And as you know, in FHIR we have these modules about workflows and medication and base services, core services, and also a communication pattern. And what we now want to do is harvesting valuable data from workflows, because workflow produce data and are fed with data, but it's only temporarily available as long as the workflow lives. And with these emerging data, we can feed a lifelong patient record. And on the other side, when we want to talk about data, we need to check up on healthcare services and may want to request workflows, request tasks. And also in a workflow, there might be some events and we want to communicate these events. And with the introduction, I will hand over to my colleague Raik.
Oh, thank you, Henrik. Yeah, let's go a little bit deeper into a realization of that triangle. As Henrik said, these parts were silos, and we try to establish this triangle and connect these systems to each other. But we had to overcome some difficulties. First and foremost, the healthcare record service, or the national EHR, in order to support FHIR natively. Until now, the EHR was solely EHD XDS driven. That means that solely documents could be stored in it, but we want to support healthcare processes on a dataset level. We want to capture intermediate states in a healthcare service process, and that's why FHIR fits perfectly to us. We furthermore had to enhance and improve the communication service, our messenger, in order to provide more semantics. We have the vision that one primary system sends a message to another primary system, and we can address modules in receiving systems, and can automate things such as the creation of messages or trigger other local modules in primary systems. And finally, the workflow engine, we had to enhance this as well in order to synchronize the data, the prescription and dispensation data with the healthcare service. But we did it. So our objective is that all these building blocks speak FHIR and relay FHIR, and we have a media break free process. So let's put or consider a specific scenario. We think that this triangle might be used in different scenarios. For instance, referral or managed care, where a managed care plan has been set up between payers and healthcare providers, or nursing, which I want to describe here exemplary now. It's the basic use case. Imagine we have here these building blocks, the medication service, which represents the newly developed FHIR service as part of our new EHR. We have the messenger in place, locally installed in a nursing home, and we have the newly developed prescription workflow engine with a synchronization function. And a nurse might regularly check the medication history of the patients and realizes that some medication runs out and a follow-up prescription is necessary. So in an ideal use case, we think that he then uses a locally installed messenger and submits a prescription request to the known general practitioner. And in the receiving system, we can interpret this message, and since the patient is known and the medication is known, a message and prescription request might be prepared so that the GP just has to authorize the message. And this message then can be submitted to the workflow engine and is processed within that workflow engine. And finally, it's dispensed by the pharmacist while it's picked up by nursing home staff. And in the background, all this data, the dispensation data and the prescription data, is automatically synced with the EHR, with the medication service. And the medication history is updated as well. And the next time when the nurse looks at this medication history, sees an updated list. So it's an easy use case. Here's one detail of our, probably you might or cannot see it, one detail of our synchronization function. We make use of FHIR operations. It's here shown in UML activity diagram, which visualizes the business logic that is executed when dispensation information is submitted to the medication service. As I said before, FHIR fits perfectly to us because we can here ensure the consistency of all the FHIR resources and the consistency of our information model behind the medication service. And we use this pattern with the further development of the medication service. We plan the medication planning as well and use the FHIR operations as well instead of using the RESTful API. Okay, yeah, that's now, I guess, one part. Now the next one is that's here, how the message is actually transferred from the primary system to another primary system. And here the novel approach of the app transfer framework is introduced.
Okay, thanks, Greg. So actually here you see how we built up the medication history for the triangle check medication history. And here we are now in the part of the triangle where the request of the prescription to the doctor office should be placed. And here we are going away from a silo. We say we have one system, we can do it everything. We say now we need to have a connection between the software system of the nurse and of the doctor system. And what we are doing here, we implemented an app transport framework. So what does it mean? It doesn't mean the content which should be delivered, it only means how it should be delivered. So in our case, we use the messenger, what you already said, built on the matrix org. And here's one example, which is not really technical, but maybe for your understanding is quite good. So first, the system of the nurse sends a message, I want the service of a prescription request. And sends, of course, the content, so the medication in our case. Then the doctor system receives it and can decide, oh, I am able to do this. So they send, oh, fine, please wait, I'm doing my process. Or in case the software does not provide this functionality, they say, sorry. And when the doctor office actually built up the medication request, signed it, and everything is done, so the nurse can go to a pharmacist and take it. You get the information is done, and then everything is done. So and you can also see through the messaging we use inside of our framework the message bundle. And here you can also see in the message header event the code of the service which is requested. I don't think I need to explain more the FHIR resource. Yeah. Now we are in the triangle which going from the, so actually, which creating the prescription. So there we have a specialized system which is a workflow engine. So in the workflow engine, the medication request is created, assigned, and automatically synchronized inside of our medication service, so our healthcare record. And then the patient or the nurse is able to go to a pharmacist and make a dispensation. And here we also synchronize exactly the point that this medication is dispensed at that time. And we fill up again here the medication history, so next time what Mike already said, we are able, or better, the nurse is able to go to the medication history list, checks it, and then make a new prescription. So and you can also see some examples. For example, from January to April, we created 200 million e-prescription, but our architecture is like this. We have a system which is good for workflow, but not for archiving. So we say, okay, we have 200, but after 100 days, we remove it. So this is an important fact why we synchronize the data or transmit the data inside of the patient record. So I think it's time for a little bit recap. We started with silos, and the important thing is silos are good for one thing. When you're going to one system and then build it up and make new functionality, system gets bigger, 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 complex, and it can do everything, but maybe we want to only have one thing good. And for that, you need to go beyond the silos and see how all the specialized system connecting together to make a digitization of a workflow, or better, of a medication, of a healthcare process. So we don't think we have one system which is able to do everything. It's always specialized paths. And we tried really hard with Lego to build up our vision. Took us maybe 5 minutes with ChatGPT, but it's working quite well. But here you see actually what you saw in the first slide, where we have the silos. We want to build complete tool set of FHIR-based functionalities. And next things we want to go for is, again, medication, but here more for the management, for planning, and of course laboratory reporting, so with the service request to the labo and so on and so on. Imaging is quite similar with FHIR. Of course, FHIR, diabetes management, and so on and so on. So, our context. And I think now it's time for question and feedback.
Any questions? Philippe.
It's great to see Germany adopting FHIR so well, and you have so many ideas on what FHIR is next. And as you're putting out so many IGs, do you have some kind of a content quality review process to make sure that all the IGs that you're putting out are internally consistent with each other.
Yeah, we try, but we get better. Yeah.
Any more? Yeah.
Is there a way for the patients to download their prescriptions and have them on their phone or something?
Yeah. So actually, we have an e-prescription app for smartphones, where the patient is able to see. Now I have the medication request with the medication. They can select also which pharmacy is next. They can also ask if this medication is at this pharmacy or should I go to another one, and so on and so on. Yeah, we have this.
And we have also an EHR client, which is obligatory, provided for the patient, where he can see all the other data, not only prescription data, all data that comes into the EHR.
But it's not necessary to have an app. Sorry, I want to continue. So actually, we have also our cards, our electronic patient cards. So the patient can go to the pharmacist and only put in the card, and everything is known by the system of the pharmacist. It's good for people who want no smartphone or who thinks I'm too old for a smartphone.
I have a question around legislation. Is there any legislation behind this that makes it participation mandatory? I know that in Germany, the Bundesländer, you have this federal system that makes it sometimes challenging.
Yeah, it's challenging. But do you want? I think.
Yes. Some applications have to be used by law. So like the e-prescription, you cannot opt out from the e-prescription. So, and there are other regulations like with the electronic sick note. This is not written down. This has to be done by law, but we have contracts between the insurance companies and the professional representatives. They make contracts that they use this system for this application or for this use case.
There's a lot of standardization going on in the EU at the moment. How are your profiling compliant with those of the EU?
Do you mean the electronic health data space?
Yeah. European Health Database. Yeah. It's an ongoing discussion, and by now we just support the issuance of the patient summary from one country to another country, and all the other use cases, communicating lab reports and so forth. Yeah, it's an ongoing specification, but yeah, it just needs more time.
And also the medication service is part of the new or the rebuild of the electronic health record, and this is a start into the European health data space.
Also regarding this, in the US there are regulations around authentication and using publishing the endpoints, using Smart on FHIR just to regulate and standardize the way, for example, allowing third-party app developers to connect to endpoints. Do you have something similar in Germany, or do you plan to adopt something similar to the US one?
Well, Smart on FHIR, not directly, but we do a rebuild of the whole infrastructure with the telematic infrastructure 2.0, and there we have OAuth principles for accessing services via the internet, not via VPN. So this is standard we're using in the future, but not specifically Smart on FHIR.
And what would be the process for a third-party developer to have access to that?
That's not specified at the moment, so we will see.
Okay.
Last question.
I think we're like the FHIR community in general is kind of at the beginning of using FHIR messaging, and that's what this is all based on, right? And then, assuming that's correct, is that correct?
No.
No. Okay. Okay. So maybe can you describe like what the communication protocol is? Like, it's not exactly REST. There was an event code somewhere. It looked like message header.
Yeah, this is the payload is FHIR messages, and this is transported via email or via the messenger based on matrix.org. So the transport layer is either email or messaging, whatever, and we send FHIR payload.
All right. Thank you.